we would like to change now to the, as a second speaker, Winan van Houdt from the Netherlands. How can we change the screen? Oh, here's Winan.
Hi, I'm here.
Hi, how are you?
I'm good, thank you.
Nice that you're joining us virtually.
Yes.
So we are very interested to hear your presentation. The floor is yours.
Well, thank you, and thank you for inviting me here. It's a pleasure to be here virtually, at least. I couldn't come because I'm actually on call this weekend, so I can receive a phone call from the hospital, but let's just hope it doesn't happen in the next half hour or so. Anyway, I will start sharing my screen. Here. Just Gerard, can you confirm you can see the screen? Okay. So my name is Winan van Houdt. I'm a surgical oncologist in the Netherlands Cancer Institute in Amsterdam, the Netherlands. Yeah, my focus is mainly sarcoma and GIST. And well, I would also like to say it's you know, my dedication is there as well. Somehow the title screen keeps jumping, but the title of my talk today is the role of surgery in basically all stages of the disease, which is an interesting topic to discuss actually. And some of the things I will discuss today might be very straightforward and not very new to all of you. On the other hand, maybe some things are new or something to discuss, and something that's very interesting and still very unclear is the role of surgery in metastatic disease. Basically, the phase where John was talking about all the time, well, in his previous talk, is where does surgery fit in there, and if so, when and where and how. So it's something we will discuss in the end. So let's start with the first part. So surgery in primary GIST is obviously the treatment of choice for almost all patients. But first, this is a bit of background that you probably all know. And I just put some pictures in now and then to see the diversity of the disease that we deal with, and also the challenges that we face as a surgeon, and not only for operating, but also for the phase before, the diagnostic phase and the decision making on what to do next. I think it's good to know that the patients usually come to the surgeons first. Sometimes they go to the GP or to a gastroenterologist, but quite often, at least in the Netherlands, it's the surgeon who makes the diagnosis. And the symptoms that patients have and that you might know are, well, it can be nothing. It can be found as a coincidental finding. But if patients have symptoms, it's often bleeding or sometimes obstruction or just, you know, a little bit of fatigue, and somehow they get a scan or an ultrasound and then they find a mass. And most patients will have a gastroscopy or another endoscopy where they find the tumor. And then it's a question that we quite often face is, do we need to do a biopsy before you do anything? And we always say yes, because we want to know what the tumor is. We want to know the mutation status. And as John said, well, we try to do a mutation, or we encourage to determine the mutation analysis in every patient, even if we don't aim to give systemic treatment at this point, but at least we know what kind of tumor we face. We know whether we can give any kind of systemic therapy, and we even can find out whether it's a rare variant that I will come back to later. We encourage always to do it in an endoscopic way. So if there's any tumor spill, it will be intraluminal, but if it's not possible or if it's difficult, then we are not worried to do a transcutaneous biopsy. We even published a paper that it is safe. It was a common project from the Royal Marsden and my institution, and that it's better to do a biopsy so you know what you should deal with before proceeding to surgery or any kind of treatment. Obviously, we will do some scanning, and some interesting things we always discuss is, you know, do you need to scan just the abdomen? Do you need to see the chest? What's the role of the PET-CT in at least primary imaging, or even if you go on in the follow-up, or if you treat systemically? These are discussions that we quite often have, and I think it's a field that is still not quite developed yet. So this is just a slide to put up, and that I always, you know, tell fellow surgeons around the country, if they say, well, if I see a mass, let me just take it out. And I tell them, you know, there's a plethora of diagnoses that it could also be. And yes, a GIST is quite often quite clear on, or at least we feel it could definitely be a GIST, but all of these diagnoses I have seen as well, that it wasn't a GIST, and I didn't even put down the gastric cancer or other carcinomas that are always, that it could also be. And in many of these diagnoses that I put down here, primary surgery is not the treatment of choice. And I didn't put lymphoma here. I didn't put leiomyoma, schwannoma, and so I tell colleagues around the country that call me, you know, I have this mass, so I just take it out, and I encourage them to do a biopsy, because I tell them, you know, if it's a lymphoma, surgery is not the treatment of choice, and it's a schwannoma, you could just leave it in if it's not symptomatic, and things like that. So this is just a slide I wanted to put down here. And if you want to read more about diagnosis, I'm sure you're all familiar with this document, the updated clinical practical, or the guidelines of the ESMO that is available online on the ESMO website on diagnosis and also treatment of GIST. But as we also know, it is always a bit behind. It was very interesting what Jon said, that you know, if you read the guidelines, that's already based on literature from maybe 3 years ago. So it's always a bit old, but at least it's helpful, and it's something you could give to local doctors if they don't know what to do. So if you talk about GIST, and if you talk about surgery for GIST, but I would say any treatment of GIST, a word that comes to mind always is, yes, it's a rare disease and it's a GIST, but it's still heterogeneous in many ways. So these are different GISTs in different sizes. You know, left upper corner is something that is sometimes found, you know, accidentally when you operate for whatever reason, and you find this very, you know, this very small lesion, which is a GIST, you know, a couple of millimeters. And then there's the picture below is, you know, a little bit larger, it's maybe 3, and then the one below is definitely larger, small bowel GIST, maybe 7-8 centimeters, and then the one at the bottom is even larger. And I even have pictures of GIST that are 40 or 50 cm. So heterogeneity is definitely something that we face when we treat GIST. It's also heterogeneity. The heterogeneity is also when it comes to the organ of origin. And you know, we all know the gastric GIST, but you have the other locations as well, and even the challenging esophageal GIST, which is not always easy, because if you have a esophageal GIST of 2.5 cm, or do you really need to do this large operation to you know, take out the whole esophagus? It's sometimes a difficult decision to take, but the heterogeneity comes back in the mutation analysis, and I know John has showed this as well, but it's something that we want to know. And this is what we do before surgery. If it's an NF1 GIST, you know, it is most likely hereditary, so we need to send them to the clinical geneticist department. If it's an SDH GIST, it might change the way we operate, you know, the patient. So it's something that I would always like to know before I operate, even in smaller GISTs. Well, we know the different exons, and I'm a surgeon, so I won't go into more details, but even this can be helpful, even, you know, if you can do a mutation analysis. This is a paper that we did together with Jason Siklik in San Diego, and we look at the different locations of GISTs in the stomach, and even there was a huge variation in mutation analysis. And if it's a GIST that is more proximal in the stomach, it is almost always a KIT mutation. And this is a figure from his patients, and then in the same paper is a figure of our patients, and it's almost the same. So we validated these results. So if you don't have mutation analysis available, at least you can make an educated guess what the mutation might be, which can be quite helpful, I guess. So this is a slide I borrowed from Chen Rout from Brigham and Women's, and he made this nice slides to show the progression basically of a GIST. So what is the lifespan of a GIST if you don't treat it, or if you treat it? And it starts with a small microscopic lesion. It can become a little bit larger that I showed you on the picture before. And then it can be a localized small lesion. It can be a bit larger, or even quite large, and then it become metastatic. And then we usually treat with imatinib, as John showed. And even if it becomes resistant, we have other agents. And well, as you see, this slide is already a bit old because we didn't put down the new agents there. And I think if you think about the role of surgery, you know, surgery is different in basically any phase that you see here. And it's something we think about as a GIST. well, as a surgeon or a center specialized in GIST. But then again, I always feel surgery should not be underestimated, because it's still the only, curative intent treatment that we have for GIST. It's the principal treatment for all localized resectable GISTs, and it can still cure the majority of GIST patients, because many GISTs are small or relatively small, and we take them out, and yes, we follow them, but it never comes back. And that's, I think, still important to know, and an important message for patients that have a GIST, that there's definitely hope, and that very often you can do it with surgery alone, or maybe with a little bit of imatinib, adjuvant or neoadjuvant. So in the guidelines, we state that small GIST, like the first one that I showed you, the very small one, and if it's less than 2 cm, we don't resect it. If it's a little bit larger, and I put medium size, although that's because it's very hard to put an absolute size on it. But if it's a lesion that I showed, on the right with the black arrow, I don't know if you can see my arrow on the screen, the mouse. But if it's a lesion like that, it's not too large, maybe 3-4 cm, it's relatively easy to take it out. And if it's a GIST, we just take it out and nothing else. But if it becomes larger, like the one below, you can probably still take it out, but it's close to other organs, can be close to pancreas, can be close to other lesions. It's larger than 10 cm, so there is a high likelihood that it will have adjuvant imatinib anyway. So for these patients, we consider neoadjuvant imatinib, and we do that more and more, and I will come back to that later. So just again, to go back to the small lesions, usually we don't do anything. As I said, we do follow-up, but very, very limited. So usually I do it after 3 months, and then 1 year later, just to make sure it's not growing. Some people don't even do anything. They don't follow them, but I tend to follow them just to know for sure that it's not a small lesion that is going to grow into one of these large GISTs. But then if it stays small, we don't do anything. But it's also something that we do as a surgeon usually. So these patients we see as well, and we follow them. So what about the larger GIST? So this is, I would say, the majority maybe of the work that a general surgeon would do if you see a GIST, although in our center we often see the larger GIST and the more locally advanced, but still. And the resection that you can do for the let's say the medium-sized GISTs are usually relatively small. And it's something that I try to tell other general surgeons in the country as well. They think, it's a gastric cancer. Maybe we need to do a lymph node dissection. Maybe we do need to do distal gastric resection or proximal, or, and I always tell them, no, don't. You don't need large margins. You just take it out. It's often connected to the stomach wall or the small bowel wall on a very, small part of the organ, and just take out that wedge. We call it a wedge resection, and then there's nothing else you need to do. And that's the same with the small bowel. Usually with a small piece of small bowel, you can resect it. And at other locations like the rectum, we always, if it's a small lesion, we really try to see if there's a transanal approach possible, because the morbidity and the quality of life is so much better if you do it that way compared to a complete rectum resection where you might have a stoma, or you might have a big operation and more morbidity, or the risk of anastomotic leakages. So it's really something we try to do. Obviously, it's not always possible. Sometimes the tumors are larger and you need to do a bit of a larger operation. And also, as I said before, we look at the mutation, because if it's an SDH, we do look at the lymph nodes, because it's basically the only GIST type that spread to the lymph nodes and that can have multiple primaries. So in those cases, we look more carefully, and if there is a positive lymph node, we tend to take more lymph nodes for these patients. Also because systemic therapy for the SDH deficient GIST is limited, not very effective. So then I think surgery is even more important, and maybe the only thing you really have. So as a surgeon who sees a lot of GISTs, it's something that you need to be aware of, that they are very fragile. They can easily rupture, meaning you will cause spill, and spill is, logically, but there's even literature that has shown that if you have spill, the likelihood of having abdominal recurrences is extremely high, and you might, have to take imatinib for the rest of your life. So it's something that you need to be, very careful with. And that's what I tell all surgeons as well. Yes, you can you can operate this patient. You know, if it's a small gist, just, you know, you don't necessarily need to send it to me if they don't want to send it, but please be careful because it's different than, you know, colon cancer or gastric cancer. And if it's a large tumor, then maybe don't, and do neoadjuvant treatment, and I will come back to that as well. So something that's being discussed extensively is whether you can do a minimal invasive approach or robotic or laparoscopic resection. And the answer is basically yes, I think you can do it, but you have to realize what I put down above, that they're fragile. I always tell them, you know, it's not a goal by itself to do it minimally invasive. If it works, it's you know, I love it because it's better for the patients and the postoperative period. But given the fact that it's fragile, that it can easily rupture, just be very careful. And if you think for whatever reason you can't handle it well, you can't feel the tumor, then maybe it's better to do it in an open way to at least prevent spill for these patients. And I have seen cases where surgeons very good surgeons from other hospitals, they try to do laparoscopic resections for 14 cm gist that was growing into the pancreas, just because they felt, you know, we are very good at minimally invasive approaches. Let's just do it. And then there was spill, there was pancreatic leakage, and then I'm very disappointed because, you know, I think that could have been prevented in an easy way. So it's something that I think we should all take into account, and I think we as surgeons that are specialized in GIST, we should educate them a bit as well. Which is and this is something that you will probably all know, but if you think about adjuvant imatinib, and it's something we deal with as well, because if we operate the patients, it's usually our task to see whether they are candidates for adjuvant treatment, and we discuss it in our MDT. And the need for it is clear, right? Because if you look at all data from Ron Di Matteo, a well-known surgeon, formerly a Memorial Sloan Kettering, and the PI of the adjuvant imatinib trials, he has shown that in the past, the 5-year overall survival in his cohort back then was only 54% after primary resection, which is, you know, the pre-imatinib era. But it's quite, if you look back at the data, I'm still quite, you know, shocked that after primary surgery, almost 50% of the patient died of a GIST. And I know it also depends on your case mix, but still. And he also showed that size matters, and that the larger GIST were at higher risk than a lower risk, but than the smaller GISTs. But it's something to take into account. And if you look at these figures, and I have some slides later, when you look at the adjuvant imatinib, you can see the difference and how this improved our treatment. So imatinib came, we all know it. You probably also, you'll most likely seen these slides, old slides from Ron, showing that 1-year imatinib did much better than if you did not give imatinib. And then there was the 3 versus 1 year trial, where also 3 years imatinib resulted in a large increase in recurrence-free survival and even overall survival. And currently, more trials are going on to give, you know, up to 5 years or maybe even longer adjuvant imatinib. The risk classification, I am sure you've all seen it before. For meeting, we always use it in clinic. I even use it, you know, when I see new patients and they want to know their risk and how likely it is that it comes back. I almost always show this, you know, this nice table and show them the risk that they have, and it's very helpful as guidance for them, and also quite often it's reassuring, because I have, you know, if I have patients with a gastric GIST with 3 mitosis, 3 cm gastric GIST, and I show them the 1.9% chance of progressive disease after surgery, then they're quite relieved. So this is a very helpful table even in clinic. So what do we do after surgery for these patients? Well, we follow them, and it's also something that we debate amongst each other. How do you follow patients? How often do you need to scan them? And this practice varies across Europe and across the US. So this is what we do. Basically, we follow low-risk patients for 5 years with 6 to 12 monthly CT abdomen. I usually do 6 monthly the first 3 years, and then the last 2 years I do yearly, but there's no clear evidence to guide this. And for high-risk patients that almost always had imatinib, I follow them in total 10 years. So they go to the medical oncologist with us when they have imatinib, and when they stop imatinib, they come back to me usually. So maybe now it gets more interesting, or more or something that we need to think about more carefully always, is what to do with these large tumors. And we, as I said, we tend to give more and more neoadjuvant imatinib for these patients. And, you know, there are many reasons to do this, because if you think about, for example, quality of life or morbidity after surgery, we feel that if you can shrink tumors and can shrink cysts, it might be beneficial to patients, although it's very hard to prove this. And it's something that we, you know, want to look into more carefully and in some retrospective and prospective papers to see whether we can really de-escalate surgery. But for example, in a gastric cyst, when it's quite large, and you might even need to do a multi-organ resection or a distal gastric resection, if you can shrink the tumor and come back to a wedge resection, I think that's a benefit for the patient. And the same for the rectal cyst, and I mentioned it before. If you manage to shrink it down and you can prevent an APR, which is an operation where you lose your complete rectum and you have your stoma for the rest of your life, and if you can shrink it down and do a transanal resection, it's much better. And the same for obviously small bowel cysts. And even, which can be beneficial, is if you have a large tumor, and if it's quite large, you really have to do an open resection. But if you can shrink it down a lot to a smaller tumor, then you might be able to do a laparoscopic resection, which is also, I think, beneficial for the patient. And when I mean beneficial, I mean quality of life, basically, because it's not going to prolong life. It doesn't make an oncological difference, but still. And then the final thing that, you know, that at least I feel is that if you treat them neoadjuvantly with imatinib, the tumors become less fragile. It doesn't rupture so easily. They become more, you know, fibrotic. There's more hyalinization. So in my, well, I really have the feeling that they rupture less, although it's really hard to prove. Well, just to give you an example, this is a larger cyst of the stomach, and the patient had neoadjuvant imatinib, and after 6 months, you can see on the left, you can see the large cyst, and then if you look on the right, with, you know, the contrast is white here, so that's the stomach, and then the black part is you know, the remainder of the cyst, and it's much smaller. And for this patient, we managed to do a laparoscopic resection, and the whitish thing here is the cyst, which is usually, it looks more reddish, more like mucosa, so and very fragile. And here it's more, there's more hyalinization, it's white, it's more, well, it's well, as I said, I feel these things don't rupture so easily, and we managed to do this laparoscopically with negative margins. And I think the neoadjuvant treatment was really beneficial for the patient. Another example is the rectal cyst, which is more difficult to see on this MRI. But here is the tumor. This is the rectal cavity, and then after imatinib, it's shrunk down quite a bit. So this is now the tumor. This is the rectal cavity, and this patient was treated with a transanal approach, saving the rectum. So in the end, it was 2.5 cm after 6 months of imatinib. There was no mitotic activity anymore. The margins were close, but that's even 1 millimeter is usually enough for a cyst. So I think for these patients, it's really beneficial. Also, something that I didn't mention is that most of these patients with these large cysts, they need adjuvant imatinib anyway. So if you are going to give them 3 years of adjuvant imatinib, we even, you know, tell the patients, and we tell you know, ourselves that it doesn't matter if you start now and do the operation 6 or 12 months later and then continue with imatinib, or if you do the operation first. You need your imatinib anyway. So then I would like to you know, have some benefit from the imatinib as well, for me and the patient, for me as a surgeon and for the patient, to well, reduce the burden of the surgery. So is there any clear evidence for neoadjuvant treatment? Well, not really. It's been hard. The trials always have been with adjuvant imatinib. This is a trial quite old already, Dr. Eisenberg, and he had primary tumors, but also recurrent metastatic tumors that were treated neoadjuvantly. And basically, they wanted to see recurrence-free survival, but also efficacy or safety, because in neoadjuvant treatment, you know, if you want to be critical, or the criticism is usually that it might not be safe, that you lose your chance to operate the patients. But in this small study, 30 patients were treated neoadjuvantly. They were all operated. So there was no patient that lost the chance to be operated on. It was safe, low toxicity. They were R0 77% R0 sections, which is still quite low in my opinion, but then again, there were recurrent diseases and even some metastatic patients. And you know, that there's a difference between the patients that were primary and recurrent or metastatic patients, which makes sense, but still the progression-free survival was for this group still quite good. And there was often, as they state in this paper, organ preservation and function sparing resections, although it's quite hard to prove this. So then there was this phase 2 study, Apollo. It was in Germany, but it's never been published, but it has been shown as a design. I think it was a while ago, I think at CETOS. And I hope the results will be published at some point. So because it's interesting, because they wanted to look at radiographic response and histological response, and also the impact of the treatment of surgery. So whether surgery was really de-escalated after imatinib, which is not so easy to analyze, because you have to do an estimation by several surgeons before start of imatinib, and then you have to see what the actual operation was, and then, you know, sort of prove that you can really de-escalate surgery by imatinib. So anyway, to finish this part, neoadjuvant imatinib, I think, can really play a role in large tumors, you know, larger than 5 or larger than 10 centimeters, especially in the really large tumors. And I think that it can be beneficial if downsizing really means de-escalation of your surgical extent or resection, or maybe to spare all the organs where it's growing into. We do it even more liberal when we give adjuvant therapy anyway, when we know in advance that it's a high metotic rate, you know, it's a larger tumor, it will have, based on the meeting schedule, adjuvant imatinib anyway, we do it in even more liberally. And also when we think it's really hard to get a complete R0 resection, we tend to do neoadjuvant imatinib as well. So there are still some questions to be addressed. For example, if it's a large GIST with a PDGFR exon 18 D842V mutation, do you want to give avapritinib as in a neoadjuvant setting? That's a bit of an unexplored territory still, but I think those things might be explored in the future. And also, I think we need to have a better answer whether it can really de-escalate surgery. And actually, even in my own center, we looked at our neoadjuvantly treated patients. We found, I think already, if I remember well, 120 patients that we treated in neoadjuvant fashion in the last 10 or 15 years. So it's something that we want to write down as well to be published. So last question that I very often get in this setting is, when do you operate? So we usually treat them for at least 6 months. And if we feel that it's the maximum time where you can really have a radiological response, then we operate. Because quite often it doesn't become any smaller after 6 months. But if we still feel we can win some and it's still shrinking, we go up to 12 months before we operate the patients. But that's more rare. In the rare event that the patient is progressive, then we operate earlier, because we don't want to lose the chance to operate. And that's basically what we do in terms of timing of surgery. So then the last part is a more interesting question is, when, as I mentioned before, when do we operate in the metastatic setting? And this is obviously known to everyone. We see GIST metastases most commonly intraabdominally and in the liver, and some rare presentations elsewhere, but it's not something we want to focus on now. But if you think about surgery in a metastatic setting, it might make some sense. And I've discussed this also, offline sometimes with other, peers around the world. For example, Chen Rout, who is a strong believer that makes sense. And in a way, it might make sense, because there are some observations that could support the consideration of surgery in the metastatic setting. So, for example, we have good responses to imatinib. It can be durable, but we also know that the response to imatinib is not maintained indefinitely, except for some cases that Gerard mentioned, that some patients are on imatinib for 10 or 20 years, but most patients at some point progress. Also, it's not like immunotherapy in other diseases. There's almost never a pathological complete response, and at some point it will progress again. And also sometimes we know that if a patient has multifocal disease, that oligoprogression can happen, and due to new acquired mutation, but it might not happen in all lesions. And if it's just one lesion, maybe if you take it out, it might take more time to proceed to second line. And although you can criticize this slide because we've just seen that sunitinib can also have a little bit of a longer effect, the median times to progression are, for imatinib in this study at least 24 months. And then if you go second and third line in these registration studies, it's 6.8 for sunitinib and 4.8 for regorafenib, which is not quite long. So if you think about this, it might make sense that if you prolong your time on imatinib by taking out, metastatic disease, maybe, it prolongs life because it takes more time before you move on to sunitinib, which is not very effective, and then you go to regorafenib, and so maybe you can do something with surgery there. But you have to state the benefit is not clear. We can't be quite sure, but you might win time, and maybe we should consider or could consider that resecting oligometastatic lesions can be resected after imatinib response. So that's something we discuss quite often in MDT. If it's a patient with the primary tumor and one metastatic lesion who has been stable on imatinib for a year, do you take it out? Maybe if you take it out, you'll have less cells that are still viable that might become resistant in the future. Maybe you take them out and you prolong the time that you can keep the patients on imatinib, because you have to keep them on imatinib. Again, the oligoprogressive unifocal lesion that I mentioned, does that make sense? Maybe it makes sense because you can prolong your time. But what I really don't believe is that you can operate, or that it can be beneficial to operate multifocal progression with a patient with many lesions that are progressive. I don't believe in any way that it can be beneficial. So what about evidence? Is there any evidence? Well, as very often in these situations in metastatic disease, not really, but there is something published about it. There has been 2 attempts, as far as I know of, to do a phase 3 trial to randomize between imatinib and surgery versus imatinib alone. There was an EORTC trial that was powered in a way that they needed 350 patients, and only 12 patients were entered into the study, and then the study was closed due to poor accrual. It has not been published. And in China, there was this study, they aimed to have 210 patients and 41 were included, and this was published. So if you look at those patients, 41 patients were randomized and 19 were operated with imatinib, and the other group had imatinib alone. And I think the most interesting part is here. Again, very, very little patients, not significant. Probably many different cases in terms of, was it progressive or need, how many lesions. But if you want to see anything here, the surgery arm did much better. But, that's all we can say. Is it reliable? Can we base any conclusions on it? I don't really think so. But at least, it's something that we can look into. Then there are many retrospective series of patients that, were operated in a metastatic field, not compared to imatinib alone. So it's really hard to say anything about this. Almost all of them had imatinib, although there was one with sunitinib and 2 studies that included more than either only imatinib or sunitinib. And if you look at the table and you look, at the top, you can see that the patients that were selected were in most cases either responsive to the TKI, usually imatinib, or unifocal progression. And the percentages of patients that were operated with multifocal progressions in most series was relatively low, 20-25%. Only here, 43%, which I feel is quite high. So at least these authors try to select the patients in terms of, who to operate on and who not. And then I think the most interesting paper on this subject is this paper from Mark Fairweather, and he collected patients from Memorial and from Dana-Farber over a period of about 14 years, 323 patients. And they were metastatic GIST that were treated with TKI therapy, usually imatinib, and then cytoreductive surgery. But they looked at their outcome in progression-free disease and overall survival. They divided the patients in 4 categories: patients with responsive disease, so basically good response overall, stable disease, a unifocal progression, so oligoprogressive, and patients with multifocal progression. And it's probably not a surprise, but if you look at the data, the patients in the black line with multifocal progression did poorly. So progression-free survival was very short. Also, overall survival of this group was, was not so good compared to all the other groups. And in the other groups, if you look at overall survival, the responsive, so the responding patients did quite well, the stable patients did well, unifocal progression patients, still did much better than the multifocal progression. So if anything, that's basically what they concluded, because it's still not hard evidence that surgery is going to be beneficial for these patients. But if anything, it's probably not wise to operate patients with multifocal progression, because outcome remains poor and it really feels like a useless exercise. But in other cases, it might be something that we can consider. Again, if you can prolong the time on imatinib, then I think it might be beneficial. And what we do is we discuss it on a case-by-case basis, depending on how many lesions, depending on the time to progression after imatinib, depending on patient wishes, depending on the morbidity of the operation, we discuss whether an operation in this setting can be beneficial. And I have to say, we do it more and more. But I think because we have the feeling that the patients that we select tend to do better. And, I think last week I even did 2 patients with metastatic GIST, one with a primary in situ and with 1 liver lesion stable under imatinib for 1.5 years. And the patient really wanted to have the operation, and well, we felt it's a good candidate. And the other one was a unifocal progression after 6 years of imatinib, and 1 lesion was growing 2 scans in a row, and it became 4 cm, while all the other lesions were still about, maybe 1 cm total. They remained stable. A quite easy operation, just a piece of small bowel. So then we operate on them and we see what happens. So in conclusion, to cover all 3 fields of surgery for GIST, yes, it's still the primary treatment for localized GIST, and we should not forget it's still the majority of patients that have an operation, and that, which is the main treatment with or without adjuvant imatinib. For larger GISTs, we feel neoadjuvant imatinib, and maybe in the future even other TKIs, may facilitate the ease of surgery and limit morbidity. And for metastatic patients, yes, we have all the new TKIs, and John has shown it nicely. And maybe we can add something with our knife to help our medical oncologists to have even better outcome. And with that, I would like to thank you for your attention. Something different than all the ips and ups, but hopefully it was still entertaining and educational. And I'm obviously open for questions.
Very much for your comprehensive overview of the role of surgery. And I especially thank you for the last part, because this is certainly a point that is a question for many patients. And as you said, there is not much evidence for either way, but this was quite a nice approach that you showed us. Are there any questions? Not live, online maybe? Yeah. John.
I had a question, and that's about radiation therapy. It's typically not done. It's not really part of our treatment in a routine way, but I do think there are select patients that do benefit from radiation therapy as one of the localized approaches, whether that could be in some patients SBRT to a liver lesion, or also we've had some luck controlling disease in terms of rectal GIST also. And so I wonder if at your center you use radiation in any of these select patients. And I just mention it because a lot of times I think clinicians don't think of it.
Oh, thank you, John. I think that's an excellent question, and I completely agree. I think in selected cases, radiotherapy, but also, cryoablation or RFA can definitely play a role. And sure, I'm a surgeon. I need to talk about surgery, but in the rare cases that patients have a lung met, I don't see a reason to do an operation if you can do easily SBRT, or if it's less morbid or even impossible to operate, then yes, I think sometimes it plays a role. And we've done it in selected cases as well for rectal GIST, sometimes for lesions that we really could not operate, also in a metastatic setting. So yeah, I think in selected cases, it's something that we should not overlook. And if you think about local therapy, also the newer other options should be, you know, on the table sometimes. Yeah.
Thanks. Are there more questions? Jane? Jane, please go ahead. We don't hear you. You're on mute probably. Yes, okay.
Yeah, it's just a question. I may already have the answers to this, I don't know, but in some cases when there are metastatic GIST patients, and obviously they're asking about surgery, they're advised, there's a fear that the surgery may trigger the GIST to grow out of control. Is that a situation that happens where the disease is still progressing and it then the sort of disturbing the body and cutting into the tumor then makes it grow faster? Is that something you're aware of, or is that just something that a patient's been told because they've got progressive disease and surgery isn't an option? I don't know.
It's a very good question, and I think it depends on the setting. I think if it's a unifocal progressive lesion, then I'm happy to do an operation, as I said, because I think in some cases I believe it might be beneficial. Although I always discuss with them, I can't be sure whether this is beneficial. We think it might be, but there's no clear evidence. But you know, so it's something that I discuss. But if they are multifocal progressive, then I am very reluctant, unless it's, you know, for symptomatic reasons, because I don't believe it's beneficial, and whether an operation is going to lead to, you know, faster progression, I don't know. I've seen cases where you know, not in GIST, but sometimes in you know, larger sarcomas that you operated on, and it was, you know, inoperable, and it was, you know, that sometimes they progress so rapidly after surgery that I don't know if it's the tumor biology or maybe just, you know, that surgery is causing some you know, attack to the immune system that somehow the tumors are growing faster. It's an area that is not well explored. I don't think there's clear evidence that it's happening, but in any way, I think in multifocal progressive disease, I really don't think you should do an operation, but then go to second, third, fourth line. Because it's doing more harm in any way. Yeah. So it's not a clear answer because it's not quite clear, but anyway, I would be careful in those situations. Yeah.
Thank you.
Okay, thank you. Any further questions? It's about time for the coffee break. So, well, Dr. van Houdt, thank you very much for your nice presentation, for spending time with us. All the best. And thank you.
You're welcome. It was a pleasure.